Yeah. Welcome everyone to the webinar on communicable diseases in conflict settings. I am Maria Kusa, the coordinator of the Academy at the Global Health Institute. This is the fifth and last installment of the webinar series on global health and conflict. This webinar series is part of the first initiatives of the GHI Academy, the capacity building arm of the Global Health Institute at the American University of Beirut. The webinar will be delivered by Dr. Abdul Rahman Bizri, as you can see. Dr. Bizri is a consultant in internal medicine and infectious diseases at the American University of Beirut Medical Center, associate chairperson for clinical affairs, director of quality and compliance program at the Department of Internal Medicine, and an affiliate of the conflict medicine program at the Global Health Institute. He is also the secretary of the executive committee of the Arab Board of Internal Medicine. Dr. Bizri established many infection control programs in various teaching medical centers in both the private and public sectors. He's a founding member and past president of the Lebanese AIDS Society and the Lebanese Society of Infectious Diseases and Clinical Microbiology. Dr. Bizri chairs and serves on several national expert committees on infectious diseases and immunization practices. He is involved in establishing and updating several Lebanese clinical practice guidelines, as well as establishing national and regional guidelines on several transmittable diseases. Dr. Bizri will be delivering his presentation, which will then be followed by a 10 to 15-minute Q&A session. Please feel free to type in your questions as we move along the presentation. Without further ado, I'd like to welcome Dr. Bizri. The floor is yours.
Thank you, Maria. Good day, everybody. We'll be talking today about the relationship between communicable diseases and conflict. And we know that there exists an association between these two entities, and it's probably also a causative relation. So the outline of my talk today will be talk about the historical perspectives of communicable diseases in conflict, how to survey and control these diseases in difficult setting, military relevant infectious diseases that are associated with the destruction of medical facilities, infections associated with mass population movement, mainly refugees and displaced, and infections associated with war injury and the resulting antimicrobial resistance that emerged because of these war injuries. Then we'll try to conclude. So let's start first with the historical perspective. We all know that the association between war and infections have been recorded since eternity. We know that many wars have been lost or won even because of the emergence of pandemics. These pandemics were catastrophic at that time, and they are still is. Many empires and many major cities have lost their battles because of the associated pandemics that resulted from war with other adversaries. And if we go back to the history of the classical war pathogens and pandemics that were famous in their association with war, we know that plague, cholera, typhus, and other common illnesses have been responsible to more deaths than what the war really has caused directly to people who really participated in the war. And the best example is the Spanish flu. We know that the Spanish flu or the influenza pandemic that occurred in 1918, 1920, immediately after the end of the First World War, the Great War, have resulted in more than 50 million deaths, where the Great War have resulted in a lesser number of deaths. Another important cause of mortality in war was tetanus in the past, where dirty war injuries and inability to sterilize wounds have resulted in millions of deaths from tetanus. So the issue of how to control and survey communicable diseases in the context of disaster or mass displacement or armed conflict is really very challenging. Since we know that we cannot rely on laboratory identification of organisms, we cannot rely on a big bureaucracy and the civil servants to work for them. We have to rely on our clinical sense. So this is why there is always an advice or a recommendation to apply an early warning system, early warning systems that are based on clinical case definitions, where we identify syndromes associated with public health concern and diseases of major what you call morbidity. Influenza-like illness is one of them, where we usually say that everybody who fits this clinical diagnosis can be included in our statistical analysis. The advantages of applying early warning systems based on clinical case definition is the timeliness of reporting, flexibility to incorporate new syndromes. For example, if we are monitoring influenza, we can incorporate another new syndrome, which could be diarrhea or hemorrhagic fever or rash. Low administrative burden and laboratory burden, so this is a really of very low cost and does not need a lot of workers, and allow identification and rapid investigation of outbreaks. However, this method had its own limitation. Although it's really a very sensitive method, yet it has low specificity and low positive predictive value, which will lead to a very high alarm of what we call false alarm rates. And this will probably make it much more difficult for us later in identifying crude departures from the statistical norms. When we come to conflict, we know that many conflicts are associated with military activity. So military relevant infectious diseases are of greater significance, and we know that people who are involved in military activity can be affected by infections depending upon the mode of usually of administration of such an infection. Foodborne and waterborne diseases are important, respiratory diseases, and all other modes of transmission are usually important. So this is why we usually look at when we want to deploy military activity or military personnel, we need to make sure that we care about food and borne water diseases, especially diarrhea, viral hepatitis A, typhoid, cholera, and others. We worry also about respiratory infections, mainly tuberculosis, viral infections, and meningococcal disease. We worry about blood-borne pathogens, classically viral hepatitis B and C, HIV, and several hemorrhagic viral illnesses. We worry about sexually transmitted infections, mainly hepatitis B, HIV, and other sexually transmitted diseases. We worry about exposure to water, mainly through wading, bathing, boating, swimming, or rafting, mainly leptospira and schistosomiasis. We worry about exposure to soil where a lot of helminthic diseases, mainly in endemic area, especially if we deploy troops to endemic areas, we have worry about these helminthic diseases. And of course, last but not least is worrying about trauma, because trauma-induced infections can be really very serious, and we know from past experience that tetanus is a major killer, and other bacterial infections can have significant mortality and morbidity. Vector-borne illnesses are important, especially if we are deploying troops or militants in areas where there is a lot of burden of vector-borne diseases. So this depends upon the area we are deploying the troops and depends upon the vector itself. So mosquitoes are associated with several illnesses, including malaria, yellow fever, dengue fever, viral encephalitis, and others. Sandflies can be responsible for leishmaniasis and other skin diseases. Depending upon the vector and the area you are being deployed, you are going to have a vector-borne illness or subjected to the risk of a vector-borne illness. Some of these can be immunized for, some we cannot immunize for. And finally, zoonotic infections. We know that zoonotic infections in the setting of military conflict is important. Rabies is one, brucellosis, trichinosis, and other infections are also of significant importance. If we go to live examples, we know that for the infectious disease risk from the Syrian conflict, which were reported in the literature, do not really differ from what I have said before. Since respiratory infections, gastrointestinal infections, and skin infections are of significance, mainly foodborne illnesses such as hepatitis A, salmonella, and Shigella. those who are related to exposure to soil, such as helminthic illnesses and parasites, exposure to water, such as bilharziosis, schistosoma, respiratory viruses and tuberculosis, and of course, scabies as a result from exposure to animal bites. However, of significance in this setting is our ability to prevent preventable infections, because vaccination activity is definitely at its lowest in conflict settings, and vector-borne infections, mainly leishmania, dengue fever, and malaria, are also significant. If we go to more recent times and we talk about what's taking place now in Myanmar with the Rohingya refugees in Bangladesh, we'll find that the medical and health risks associated with the Rohingya refugees in Bangladesh are mainly those related to water sanitation, especially waterborne diseases, outbreaks, cholera, bloody diarrhea, typhoid, hepatitis E, A, and others, food security related and nutrition related diseases such as diarrhea, environment and shelter, and non-food items related such as malaria, Japanese encephalitis, and other foodborne and hookworm diseases. In the setting of the Rohingya refugees, healthcare-related infections, especially from vaccine-preventable diseases, are important because those group of refugees were not well vaccinated. As gynecological and obstetric care is important because of sexually transmitted infections, including AIDS. And what's really missing in our response to prevent these diseases is our inability in the conflict setting to get appropriate medical history and medical information from the refugees. So put all of this setting together, all of these risks together, put them in against an increased vulnerable group with malnutrition and difficult to access, such as the Rohingya refugees, and you will probably end up with a nightmare scenario. Let's go to the other component of the war, which is the destruction of medical facilities and sanitary public health infrastructure. Mind you, the Syrian war is a good example where various adversaries have considered medical facilities as what you call strategic assets, and they targeted them in order to force people to leave certain areas because of the lack of medical facilities. And if we go to the Syrian example, the result of a shattered health system in Syria is that more than 50% of public hospitals were completely damaged and destroyed. Around 30% of primary healthcare facilities were put out of service. There was almost practically no ambulance service exist. Very poor supply of clean water, electricity, fuel that will probably are necessary for building a good sanitary infrastructure, and the critical shortages of essential medications was also there. So what is really worrying was a significant drop in immunization coverage rate, because before the war, Syria used to be one of the countries with the highest immunization coverage. During the conflict and war, the immunization rates have dropped significantly, leading to various vaccine-preventable diseases. So let's try to reconstruct our now scenario. We have a humanitarian emergency or conflict. We have a breakdown of regular health services. We have major disrupt of our routine vaccination program. We have increased susceptibility to communicable diseases, mainly those that are vaccine-preventable diseases. If we put all of this scenario together in the context of displaced population and refugees that are difficult to access, living in extreme conditions, and lack basic sanitary infrastructure, and there is no poor or surveillance, then you can imagine what a very poor and grave outcome we are going to expect from such a combination. And if we look at the people who reviewed the medical literature for vaccine preventable diseases in a humanitarian emergency, we'll find that the same diseases are repeated again and again: polio, measles, rubella, mumps, meningitis, yellow fever, viral hepatitis, rotaviruses, cholera, and others. Mind you, these are all vaccine-preventable diseases, so this tells us about the significance of keeping vaccination and immunization in the setting of conflict to prevent communicable diseases. If we look at also back, if we go back to the Syrian example again, we probably the famous polio outbreak that occurred in Syria. We know that Syria has been polio free for the past 20 years or 15 years before the conflict. Now we had the re-emergence of wild type polio in Syria. Luckily, this has been contained, but at a very huge cost. 27 million children needed to be vaccinated several times in Syria and the countries surrounding Syria, including Lebanon, Turkey, Jordan, and other countries. Another vaccine preventable disease outbreak took place in Syria, Turkey, and Lebanon is the measles outbreak, then followed up by a mumps outbreak, and most recent was the hepatitis A outbreak that affected Syria, Lebanon, and Jordan. If we move to infections associated with refugee, we know that infectious diseases and communicable diseases in refugees is really a challenging problem because this population in itself is a challenging population. In the acute crisis, we know that we are moving refugees from one area to another under extreme conditions. We are placing them under very difficult conditions. We are moving people who were subjected to a different epidemiology to a country with also a variable epidemiology. So social unrest in the country, which necessitated to start with the movement of the refugees, will lead to low immunization coverage and to decrease in sanitation. So located in difficult conditions, those refugees will facilitate the transmission of infectious diseases among this group of people, mainly crowding, extreme poverty, no sanitation, no public health infrastructure, and no access to healthcare. However, when this problem becomes more chronic, when the acute crisis wanes off, then we are faced with another problem in the health of the refugees. This is when you call the paradoxical reversal of health trends, mean that people, mainly UNHCR, NGOs, international governments, international community is more interested in the health of the refugees. So everybody move towards giving them aids to the refugees. And you have to remember that refugees are mostly settled in countries next to what you call underprivileged locals of that country. So this is where the competition starts again between refugees and the host community, because refugees now are probably given better vaccination coverage, better nutritional supplements, better surveillance, and so on. And however, the contradiction between the refugee and the host community will continue, because those refugees, sometimes because of political reasons, sometimes because they are what you call undeclared refugees, they are unofficially registered, it will be very difficult to access them or to survey them. The most difficult scenario is probably have been experienced in countries such as Jordan and Lebanon and in Nairobi. Where we have what we call the urban refugees. The urban refugees is not what happened to the Syrian refugees in Lebanon. Most of the Syrian refugees in Lebanon, they were not located in tented settlement or very well established what we call camps. They were located everywhere. So this is what we refer to as the urban refugees. They were integrated with the local community in very heavily populated cities. This is probably makes them very difficult to access or survey. And this schematic drawing will probably summarize the problem that Lebanon has faces with the Syrian refuge, where Lebanon now is believed to be the country with the highest per capita number of refugees in the world. And as a result of that, and based on what I have said before, let's look at the what happened in Lebanon as irrelevant to the conflict crisis. We had the Leishmania outbreak. Lebanon is supposed to be free of Leishmania. If you look, you can see that the Leishmania outbreak in Lebanon has affected mostly children. And these are real pictures of children who were treated at our medical center and our healthcare facilities, who really has acquired leishmaniasis as a result of the Syrian conflict in Lebanon. And these are the numbers as projected by the Lebanese Ministry of Public Health. You can see that leishmania was almost non-existent in Lebanon all through until we started receiving the influx of Syrian refugees, and most of the, as a result of the Syrian conflict, and most of the cases were among those refugees. The same is what happened with measles. If you look at the measles in the statistics about measles in Lebanon, we know that the last outbreak occurred in 2007, and Lebanon had really a very good control of the measles until 2013. In association with the Syrian influx, we started having a huge number of cases of measles that we are still struggling. The same is what we call communicable dermatological illnesses. Scabies is one. This is an example of the number received by the primary healthcare units in 9 months period in Lebanon from Syrian refugees coming because of the conflict. The same is true also for lice. These are all the example of communicable dermatological diseases. And finally, since we have referred to before to what we call water-related diseases and foodborne diseases, viral hepatitis A is a good example where you can see the numbers of cases of viral hepatitis A has really surged a lot as a result of the Syrian conflict. Tuberculosis is another example of respiratory illnesses that have surged because of the Syrian conflict. This is what you call we know that the non-Lebanese are now exceeding the Lebanese as number of cases of tuberculosis registered in Lebanon, and this number of cases are becoming more and more. Now in 2017, they represent 53% to 54% of the number of the new cases. So the infectious diseases complication associated with combat-related injuries. We know that combat-related injuries were responsible in the past for a lot of mortality. During the Spanish-American War, one in 8 people injured used to die because of combat-related injury. The numbers started shrinking down with the advancement in the techniques we are using and better understanding of how to deploy troops. But in more recent time, we have the Iraqi war, the American war on Iraq. This war on Iraq had political consequences, but it had also microbiological ramification. And the most important microbiological ramification was the emergence of multi-drug resistant bacteria. People started talking about extreme and multi-drug resistant Acinetobacter baumannii complexes, the famous Iraqi Bacter syndrome. We started talking about other gram-negative resistant and gram-positive resistant bacteria, what we classically refer to as the escape pathogens. And the hypothesis, which we probably believe is responsible for the emergence of multi-drug resistant bacteria due to infection, is multifactorial and related to a specific situation. The most important is definitely nosocomial transmission through medical delivery and evacuation. But in the case of Gaza, for example, there are documents that and reports that that the heavy metals, mainly depleted uranium, used in munition and ordnance used by the Israeli army in bombardment of Gaza and other areas, probably might have contributed to the emergence of multi-drug resistant pathogens. So the risk factors associated with wound injuries and the ability to transmit these resistant bacteria from one person to another are definitely all summarized in one report from our institution, where we believe that several factors have contributed to the emergence of drug resistant among wound injuries, and this is why we're seeing more Pseudomonas aeruginosa, more Acinetobacter baumannii complex, and more Staph aureus in wound injuries, and these wound injuries can now transmit this resistance from one country to another. And this is an example of an experience in Lebanon where the cluster bomb munition used by the Israelis to bombard Lebanon in 2006 have resulted in increased rate of wound infections by Pseudomonas acinetobacter and other multi-drug resistant bacteria. In more recent times, this is a summary of most report and published data about the multi-drug resistant pathogens associated with war injuries from Iraq, from Syria, from Israel, and from Lebanon. And you can see at the list here that unusual organisms and difficult to treat organisms such as Acinetobacter, such as Pseudomonas aeruginosa and Staph aureus are the most importantly isolated. And to summarize this report, we know that from Iraq, the infection rate with wound injuries was as high as 50% sometimes. Staph aureus and Acinetobacter, the famous Iraqi bacter syndrome, that really was transferred from Iraq to the United States and to many other parts of the world. In Syria, Pseudomonas aeruginosa, which is a very well-known multi-drug resistant pathogen. In Israel, Pseudomonas aeruginosa and Candida, and in Lebanon, Staph aureus and Pseudomonas aeruginosa as well. And in more recent data collected by our group, we can see here that multi-drug resistant organisms do account for a significant number of microbiological war injuries to the extremities, where Acinetobacter constitute the largest group of organisms responsible for these injuries. And this is also data collected by the conflict program at the American University of Beirut, where we reviewed the osteomyelitis cultures related to war injuries, and you will find that MRSA, which is a resistant pathogen, and Acinetobacter, which is also a resistant pathogen, and Pseudomonas aeruginosa are notoriously heading the list of the organisms that can cause these infections and transmit it to other patients. So, to conclude about this part, we know that infectious complication of war-related wound injuries can be tremendous. It's not only the issue of resistant bacteria, it's also the issue of developing serious infections such as sepsis, osteomyelitis, and the percent of infection will increase depending upon the site of injury. Infections in the abdomen, injuries in the abdomen will cause more infection than injuries in the extremity and then in the thorax. Yet, as a result of that, we are now using all drugs that we thought we are not using before. So Lazarus of Bethany, or Saint Lazarus, as we know, is somebody who has risen from death. And in fact, because of the multi-drug resistant bacteria we are facing, some compounds that we never thought that we are going to use in modern time have been reused again. A good example is the use of colistin to treat multi-drug or extreme drug-resistant Pseudomonas aeruginosa and Acinetobacter. Minocycline in its new formulation as tigacycline has been used also to treat multi-drug resistant E. coli, Klebsiella, and Acinetobacter. Other drugs, including sulbactam, phosphomycin, aminoglycosides, and chloramphenicol, now are being utilized more and more for that purpose. So finally, to conclude our discussion or our presentation, we say that the association between war and conflict, between conflict, war, and infectious diseases has been established since antiquity. Classical war, pestilence, and pandemics during older time, and emergence of antimicrobial resistance in modern times. Political and military conflicts will result in more injuries and more wars, and will result in more complications such as multi-drug resistant and extreme drug resistant bacteria that are difficult to treat. Communicable infectious diseases are of utmost importance in the conflict setting because they have the potential to cross border, alter local epidemiology of disease, and cause significant morbidity. This effect is being augmented via the presence of susceptible population, mainly refugees and the displaced people. So this is why in order to face the threat of communicable diseases in conflict setting, we need to have collaboration, cooperation, and consolidation among various parties to have better evaluation of burden of communicable disease, better surveillance to monitor, control communicable disease, including immunization practices and early treatment, to make sure we ensure adequate sanitary infrastructure and environmental control, plus proper settlements of refugees, sharing of experience, consensus, and position paper and guidelines, because these guidelines are missing and lacking for most of our practice in this setting, readiness and collaboration among various stakeholders. And since I am now speaking from a medical institution, that's a medical center that teaches and trains future doctors, I believe strongly that we should integrate conflict or crisis medicine and refugee medicine in our medical curricula and training of our postgraduate students, because we are living in a dangerous world and we are living in an area where unfortunately conflict and crisis will continue with us for some time. Thank you. So, any question?
So we will be taking a Q&A if anyone has questions. So the questions will be on the presenter chat. So if you can type in your questions.
Okay. Okay. So I have several questions on my presenter chart, and I will answer the first question. Is there research that could help in solving these scary problems? Definitely, you see, most of the research in the past is based on evidence-based medicine, and evidence-based medicine is usually where you have a controlled setting. Unfortunately, what we are dealing with is extremely difficult setting to control, where you cannot always repeat the same scenario. So this is why we are using sometimes evidence-based medicine to apply in a scenario where it is very difficult to mimic the same situation. But definitely our institution and the conflict medicine program is indulged in several research projects that you are welcome also to participate or contribute later to, that mainly about war injuries, about vaccination practices in this setting, where we need to make the best out of a very difficult situation. And the literature is now emerging more and more about the such data and how to benefit from this data in order not to commit the same mistakes that others have committed, or the shortfalls and pitfalls that others had when they encountered such a difficult condition. I have another interesting question. Somebody is interested in the Leishmania outbreak in Lebanon. Ask me, can you tell us please, for such vector-borne disease, especially in the case where we don't have the vector in Lebanon? We have the vector in Lebanon. It's the sand fly. We have a very similar environment, similar to that of Syria, mainly in the Biqa' Valley and in the north of Lebanon. And when this outbreak happened, we had a very beautiful response in Lebanon, where multiple stakeholders, including the infectious disease community, the Ministry of Public Health, the WHO, and other players, including the pathology department of AUB. We all get collectively together, coordinated our act. It's interesting to know that when we start encountering these cases of leishmania, we never had the leishmania treatment in Lebanon, and most of our doctors have never seen a leishmania case before. So we started educating the doctors, the dermatologists, the frontline physician, the physicians that work with the Ministry of Health. We started educating them how to identify leishmania, how to collect an appropriate specimen, how to diagnose it properly, and how to give the injection locally or intramuscularly. And we provided the treatment free of charge, and later then for very nominal fees, and we were able to contain this outbreak. Is there a specific test that let us know if we are Staph aureus carrier or no? Yes, there is a specific test. If you are a Staph aureus carrier, usually the carriage sites are mainly in the nostrils, and to a lesser, and then in other body sites such as the umbilicus, the axillary area, the inguinal area, and the rectal orifice. So the chances that you are going to transmit your carrier to other people will probably feed from the nasal orifice. So we can do nasal carriage check. And in fact, at our medical center, if we are suspecting somebody with nasal carriage, we usually collect specimens from the site where the carriage occurred and look for them. If the patient is a carrier of MRSA, then we probably we may isolate them. I have a question from the I have a question from you are all invited to the conference microbiology causes of lower respiratory tract infection in the context of the Syrian crisis. Okay, this is somebody is inviting us, and we're glad to look at that and communicate to see whether we can do something about it. I have a question from. I have a question about the. Glad to listen from you. I have a question regarding Staphylococcus as it can be found in our hand face. This is specific. We answered that. What is your opinion? The highest medical priority that should be considered NGOs in Lebanon after the Syrian crisis. This is very interesting. You see, NGOs have now what you call specific role because NGOs in general usually some of them put all of their efforts with the refugees. Some of them put their efforts in what you call a specific group entities for refugees. And we have just finished a report for publication soon. We know that there are a lot of NGOs now who pay attention for diarrheal illnesses. There are a lot of NGOs who pay attention for respiratory illnesses. There are a lot of NGOs who now pay attention for vaccine preventable diseases and immunization practices. But unfortunately, some diseases are what you call neglected among refugees in Lebanon, specifically chronic viral hepatitis and brucellosis. These are diseases that are neglected either because of their prolonged incubation period or because of the sophistication of their treatment and the cost of their treatment. The Syrian refugees in Lebanon now are with us for the 6 or 7 years now in a row. Many of them had chronic viral hepatitis B or C. They don't have access to treatment. And my belief is that if they tend to be neglected more, they are going to develop serious complications of these fatal illnesses that can be treated easily, and and in the case of hepatitis C, can be cured easily. How significant were the measles, mumps, hepatitis experienced in Lebanon? Did the MHO survey the affected? What interventions were there? Well, you see, they were very serious because the hepatitis, the measles outbreak now is reappearing again. Now Lebanon is experiencing another measles outbreak soon. And as you know that most of measles outbreak are usually followed in 1 to 2 years time by mumps outbreak. What we did when we started recognizing this outbreak, we started what you call investigating the cases, and we sent teams for investigation. The epidemiological surveillance unit of the Ministry of Health did very nice work, and we started vaccinating first people who were in the vicinity of the identified cases. Then we started having national campaigns of strengthening immunization, and we thought that we were controlling the measles outbreak, but we know that we controlled it a little bit, then it started surfacing again. So now we are indulging in other immunization activity again. As for the hepatitis A, this was a much more complex outbreak because hepatitis A vaccine is not available by the Lebanese Ministry of Public Health. Although we, as part of the group who investigated this outbreak, we recommended the introduction of the vaccine to Lebanon, but because of the priorities given to rotavirus and to pneumococcal vaccine, it will be very difficult to have a mass vaccination of hepatitis A in Lebanon. But the answer was really in improving access to sanitary and safe water, and to ensure better water facility and a clean water facility, and to start monitoring the activity of hepatitis A more, which is unfortunately still going on, but with a lower rate than what happened a few years ago. You mentioned the use of Lazarus medication for MDR pathogen. Do these medications have serious and dangerous side effects? This is very interesting because, for example, colistin or coleomycin is a drug that if you want to approve it now with the stringent FDA or what you call European medical agencies specification, this drug will fail any safety what you call regulation. But because we needed it, because we believe that it was used in the past, now we are using it again. These medications have a lot of side effect and toxicity, and they have a lot of difficulty in understanding their true pharmacokinetic and pharmacodynamic profile. In a conflict zone, we face many injured patients having antibiotic resistance. How to deal with this dilemma? You see, in the I believe that the antibiotic, the emergence of drug resistance to start with in the conflict zone was a result of overuse or poor use of antibiotics improperly, either at the immediate setting or later when we transfer our patients. Although we have to know that many of our countries in the region were under siege because of what you call political decisions done by many other countries. So this is why maybe the quality of the medications in some countries in the Middle East were not really as appropriate. So we have really to start finding guidelines. It is very difficult to look at war guidelines in managing war injuries. The Americans have their own guidelines. They are mainly designed for the use in when they deploy their military. Other Europeans guidelines, but in Lebanon, in occupied Palestine, in Gaza, in Jordan, and in Iraq, the civilian centers are bearing the major responsibility for managing military casualty. And this is where really the difficulty lies. Any future plans for taking more advanced measures to protect against various transmission of infectious disease from patient and other medical centers? We know that the transmission of infection in a medical center is a challenging problem. It's not only restricted to war injury, it's everywhere. Nosocomial infections or hospital-acquired infection now are one of the largest pandemics that is facing the world and challenging the medical community. People are afraid that we may be going back to the era of no antibiotic resistance. because of the emergence of very high resistant organism and our inability to find the new drugs to treat them. So this is why we need to rationalize the use of antibiotic. We need to have antibiotic stewardship programs in the community and in the hospital setting, and to have antibiotic policy use. Okay. In conflict zone, we face, we talked about that. Thanks for that. I am wondering about what are the realistic practical steps taken by most impacted countries receiving refugees, especially urban refugees such as Egypt and Lebanon, to implement necessary measures to prevent and control infectious disease epidemic in their country. Do they have enough awareness on a high level about the risk even on their population? Do they have the technology necessary and public health expert to deal, especially no public health schools in the region generally lead to scarcity of human capacities and expertise. This is very interesting. I think this is really a very challenging problem. We're facing it every day in Lebanon, and the Syrians faced it before the war and when they received Iraqi refugees. Where when the refugees started being integrated into the community, it will be very difficult to trace them, and it will be very difficult to monitor them. And we have to know that various epidemiologies exist among various countries, even in the Arab world, even in the neighboring countries. A good example is leishmania. In Lebanon, we had almost zero leishmania cases, while in Syria and in Iraq, it's a very well-established endemic entity. So when these refugees are integrated into major cities and an urban setting, it will be, they are able to transmit disease, and it will be very difficult to trace them and survey them. However, it is also bad for them because they will not be able to be reached by healthcare systems that are usually designed and in place for refugees. So this is a challenging question. And since you are a public health student studying in the United Kingdom, I think this will be a very nice project to start thinking along how to usually assess the burden of communicable diseases in urban refugee settings. Okay, any more questions? I'm lost because I have so many questions. How would the general rate of the refugees being mobile affecting surveillance of infectious disease and vaccination effort? You see, the best way to really to monitor a refugee population is to place them in a setting where, first of all, the necessary infrastructure, public health infrastructure, is there. The necessary advanced primary care clinics are there. And since they are put there in this setting, you can survey them and monitor the emergence of resistance. And you see, refugees are not all the same, because some of them have come electively, some of them have come forcefully, some of them came by land, some of them came by what you call the seaboat people in compact sea and unhealthy mode of transmission. So the risk is usually variable among this group. But the fact that they are mobile and they are not in one place, and they can usually be active or dynamic. They can go back to Syria, for example, in the case of Lebanon, and forth and come from Syria to Lebanon and vice versa, will make it a nightmare for us to monitor the true incidence of disease. Okay. Thank you. And my coordinator tells me that it's time to stop, and I have to listen to her. So thank you, and thank you thank the audience for their interaction. And my email is ab00@aub.edu.lb. I'll try to type it now. If please you want to continue the discussion, or you believe you have any fruitful interaction or plan to collaborate later in this aspect, either with me directly or with the conflict medicine program, which I'm glad to be a member of this program. We will be willing definitely to respond to that. So thank you again for bearing with us and for your interaction. And please, any question I didn't answer or you did not like my answer and you want further to discuss it further, I'm glad to answer it through email, ab00@aub.edu.lb, and I will type it now.
Perfect. Thank you so much, Dr. Bizri, for this lovely talk. We look forward on having future webinars with you, inshallah. And thank you everyone for joining us. I will be typing the email now. And as I mentioned, this is the last installment of this webinar series. I encourage you all to stay in touch and to keep checking our website for any future offerings that we will be giving, and especially around fall 2018. Thank you so much.